The first part of this lecture is really going to look at the potential health benefits of exercise and explain the differences or the fundamental differences between what moderate exercise is and its benefits and what high intensity interval training is and what its potential benefits are as well. Okay, because high intensity interval training used to be in the realm of the elite exerciser or those trying to increase performance, enhance performance. But really there's been a lot more work recently thinking about its potential health benefits and how these may be equal or potentially better than doing moderate exercise. The second part of this session is going to look at the relationships between non-responders, positive responders and adverse responders to exercise. So just as you know, there'll be some drugs that people will take that may have a positive response on those people. There are some responders, so they're positive responders. You may have some people who have an adverse response to a particular drug, or some people who don't respond to it particularly well at all, the non-responders. And it seems to be the same with exercise. Some people may have a positive response, some may have no response at all, in particular health risk factors, and others may actually have an adverse response. For example, their blood pressure may get worse with exercise. And so that's what we'll talk about in the second session. So first of all, what I want you to look at, I want you to just look at each of these review questions and just think, right, are each one of these true or are they false? And if they're true, why? Do you understand why? But also, if they're false, I want you to think about why they're false as well. Okay, I will go through them in a second, but what I'd like you to do is just pause your presentation, have a think about each one, and then press resume when you're ready to go. So first, blood pressure equals cardiac output divided by total peripheral resistance. Did you think that was true or false? Well, it's actually false, so hopefully you got that right. Your blood pressure does equal cardiac output, but this time multiplied by total peripheral resistance, not divided by. So remember the pressure, your blood pressure is the pressure exerted on your arteries. So it's completely relevant to that cardiac output. The greater the heart rate, the greater the stroke volume, so therefore the greater the cardiac output, the more blood is being pressed against those arteries. And your total peripheral resistance, that relates or corresponds to the resistance on your vesicles, on your vessels, on your arterioles primarily. So the more they're constricted or vasoconstricted, the greater the total peripheral resistance. And the more they're dilated or vasodilated, the reduction in total peripheral resistance. So in other words, your blood pressure is your cardiac output multiplied by your total peripheral resistance, because the greater your total peripheral resistance, the greater the blood pressure. Remember, increased total peripheral resistance means vasoconstriction. Second one, systolic blood pressure is the pressure exerted against arteries on left ventricular contraction. Diastolic blood pressure is the pressure against arteries during left ventricular relaxation. Hopefully you all thought that was correct, and it is. Okay, and remember the average blood pressure is 120 over 80 millimeters of mercury. And just so you remember it, the difference between systolic and diastolic in health is proportional to your stroke volume. So if it's 120 over 80, that's 40. And so that stroke volume is proportional to the pulse pressure, which is equal to 40. Blood pressure is sensed in baroreceptors in the aortic arch and carotid arteries. Again, that is correct. And again, those baroreceptors, they respond to changes in blood pressure, either increased or decreased, by enhancing or decreasing stroke volume, enhancing or decreasing heart rate, or by causing vasoconstriction or vasodilation. So number 4, people that report carrying out regular exercise training are healthier with less hypertension. Again, that is correct. If you report carrying out regular exercise training, people are generally, they have less hypertension. If you take up regular exercise, number 5, you will reduce your blood pressure. False. There is no way of knowing whether this will be the case as an individual. And this relates to the adverse responders to exercise. Some people who exercise regularly or doing high intensity interval training will actually get an increase in their blood pressure with training or with exercise. So they are adverse responders, so you won't necessarily reduce your blood pressure. So the next question really is, why do we exercise? There are lots of potential reasons why you might exercise. It might be because you want to be fit and healthy. It might be because you want to prevent disease, whether that's cancer, diabetes, obesity, depression, heart disease, stroke, blood pressure, you name it. Of course, there are lots of other reasons you might want to do it. You just feel good about it. It makes you stronger. You're doing it for your sport reasons or your mood or socially. You might be addicted. There are lots of potential reasons. It means all kinds of different things to different people. And it also means it's also relevant, what is the endpoint that you're actually interested in? So if you have hypertension, then you may be exercising to try and reduce that hypertension. And of course, remember, you can be obese and be metabolically fit. And likewise, you can be slim and be metabolically unfit, for example, by having high cholesterol or high fatty acids or fatty liver. So exercise and obesity, clearly they're often linked, but it isn't always the case that they are linked. So how important is exercise? Well, on average, of course, your headlines that drive a healthy lifestyle, the average person will live about 10 years longer if they do regular exercise throughout their life. So what are the kind of things that can help you live as well as this physical activity? Well, of course, you're more likely to live a healthy life if you're a non-smoker. Everyone knows this. If you maintain an appropriate body mass index, less than 25. Now, we all know body mass index isn't the greatest measure in the world. Your body fat index using calipers or your waist hip ratio, your waist height ratio, your waist circumference, they're all theoretically better. But it's fine as a measure for, in particular, as people get a bit older. Of course, as well as that, you want to maintain a balanced diet. So in general, you want to have, in terms of calories, less than 30% of your calories should be coming from fat, of which less than 30% should be saturated. You'll be wanting about 60% of your calories, 70%, depending on what you're doing, from carbohydrate. And you need roughly 0.8 grams per kilogram of protein, so per body weight. So we tend to throw that at 1 gram per kilogram of protein in your diet. Okay, so if you weigh 80 kilograms, have roughly 80 grams of protein in your diet per day. Seems about sensible. And you don't want too much exercise. So these are old units here, so ignore these. It isn't less than 21 units per week. It's been decreased in recent years down to 14 units per week for both males and females. Okay, so that's 2 little drinks per day. And actually, alcohol can actually be good for you. It can be good for your cardiovascular system. For example, moderate or low levels of alcohol seem to be quite beneficial for that. So you don't want too much. And of course, regular physical exercise, what we're really going to be talking about today. So World Health Organization guidelines and Australian government guidelines are you should be doing 5 by 30 minutes of moderate aerobic exercise per week. So equals about 150 minutes, as well as 2 strength training sessions a week as well. So that's a significant amount of exercise that they recommend. Now, instead of that 5 times 30 minutes, you could theoretically be doing 3 by 25 minutes of high intensity training, aerobic training. So 5 by 30 minutes of moderate exercise or 3 by 25 minutes of high intensity exercise to give those potential benefits to you. So what about obesity and type 2 diabetes and physical inactivity? How are they all linked? Well, we all know that obesity is a major problem and that obesity leads to type 2 diabetes and that physical inactivity is often linked with obesity and type 2 diabetes. And globally, 3 million people die due to obesity. Another 500 million are classified as obese. And remember, that doesn't mean overweight, that means obese, so your BMI above 30. Okay. And obesity, as you'll know, increases your risk of type 2 diabetes mellitus, as well as cardiovascular disease. Because obesity, especially if it's apple-shaped, so it's obesity around your waist, that is very metabolically active fat. And that fat is the bad for you fat. That is the one that produces hormones that lead to insulin resistance and therefore onto type 2 diabetes mellitus. And as you have type 2 diabetes mellitus, that gives you an increased risk of cardiovascular disease. And your sedentary lifestyle is obviously linked to type 2 diabetes and cardiovascular disease as well, because they're all inherently joined together as a great big loop. And your physical inactivity is associated with a low VO2 max or aerobic capacity. And remembering what VO2 max is, VO2 max or aerobic capacity is just your ability to use oxygen. Okay, so it's basically how healthy is your lungs, how healthy are your heart, how healthy are your blood vessels, how much oxygen can you use per minute per kilogram of body weight is what it's measuring. And it's one of the best overall markers of health there is out there. So it used to be used looking in terms of elite athletes and performance, but actually it's one of the best measures of your overall health, of your risk of diabetes, of your risk of cancer, of your risk of neurological defects. It's just a great overall marker of your overall morbidity and mortality, so your overall health. And of course, therefore, a low VO2 max, like I've said, is a major independent predictor of all-cause premature mortality, so early death. And if you want to know how it's determined, and there are lots of ways it's determined, but the best way is they measure oxygen consumption during a maximal graded physical exertion test. This is often on a bike or on a treadmill, where you basically start at a certain speed or a certain wattage, wearing a mask that's measuring your oxygen usage and CO2 production. And you exert yourself to a higher and higher and higher level until the system basically finds out the maximum amount of oxygen you are using per minute of kilogram body weight. Okay, so it's all about how much oxygen you're using and how effective that is. So when we're thinking about risk factor modification, so how do you change the risk factors for health that you might have, there's very good evidence to show that the risk factors for individual diseases can be reduced with exercise. So for example, if you can increase your VO2 max, your aerobic capacity, that will reduce your likelihood of all-cause mortality, so cancer, diabetes, whatever it might be. And that occurs in about 80% of people benefit in terms of aerobic capacity. About 65% of people benefit in terms of how well their insulin can act. And if your insulin acts better, it means you have a much lower chance of getting type 2 diabetes mellitus, in other words, of getting insulin resistance. It reduces blood pressure in about 50% of people. And blood pressure, of course, is a major cause of stroke. So it reduces the likelihood of getting a stroke. It increases your HDL, that's your good cholesterol, in about 70% of people. If your good cholesterol goes up, your good cholesterol mops away your bad cholesterol, so you've got a reduced chance of vascular disease, so atherosclerosis, for example. And depending on what it is, it can promote bone and muscle mass. And if you've got an increased muscle mass, in particular bone mass, in fact, you're much less likely to get fractures because your bone mineral density is at a higher level, and so therefore you're less likely to get fractures. But of course, exercise does all these great things, but also what it does, you get a decrease. So if you just stop exercising for a short amount of time, you start to lose some of those positive benefits. And some studies have shown that improvement in insulin action that you get with exercise can be reduced or start to be reduced in just 14 days of inactivity. So whilst you get positive benefits, if you stop, those positive benefits start to disappear again. So, like I said, the physical guidelines or current government guidelines of 5 times 30 minutes of moderate intensity exercise per week and 2 strength trainings. But if you look in a worldwide activity chart, if you like, if we go to the UK, more than 60% of people self-report of not doing that amount of exercise. 30 to 40% of Australians self-report to not be doing that type of exercise. And so self-reporting, obviously people over-report these things, so the numbers are probably much, much greater than that. So what are the reasons? This 5 by 30 minutes, 150 minutes a week, this high energy expenditure activity regime, it might not be optimum for reducing the risk of developing type 2 diabetes and cardiovascular disease. Lots of people can't do it. They don't have the time to do it, or they don't think they have the time to do it. So what can we do about this? How can we change this? How can we move from a system that isn't really working to a system that might potentially work? So do you need to do that full 150 minutes of moderate exercise? And remember what moderate exercise is. Moderate exercise is you're going for a run, or you're going for a cycle, or you're going for a very fast walk, and you're able to hold a conversation with the person next to you just about. Okay, so that's your 150 minutes. Or you can do high intensity for 75 minutes, remember, and that's where you're running or cycling and you can't hold a conversation with the person next to you, but you're not absolutely killing yourself. Okay, but actually, is there anything where you can use less time to try and do these activities? So if we just have a little look at this graph that's in front of you, on the x-axis it's just intensity in watts, so that's the power output, how much effort are you putting in essence. And on the y-axis is just your aerobic capacity, it's your oxygen usage, your oxygen uptake. And your moderate intensity exercise, remember, If you're working at a relatively low level, that's where you're doing your 150 minutes per week, and you can chat to the person next to you. You've got your high intensity exercise where you're doing 75 minutes, so 3 by 25 minutes a week. And that's where you're exercising at a level where you can't hold a conversation with the person you're with, but you can maybe throw out the odd word at them. And then you hit your aerobic max, okay, where you're working at absolute max, 100% oxygen uptake. You can't use any more oxygen. You're at your lactate threshold, the point at where your lactic acid levels in your blood are about to go above normal. Okay, in fact, it will have gone above that level earlier on. But your aerobic max, you can't process any more oxygen. Okay, so in essence, that's your VO2 max. And so you then move into the zone of your high intensity interval training. So this is where you're working anaerobically, where aerobic respiration really isn't as relevant. And this is the area where you used to have the elite athletes doing all the work. Okay, so these are the guys who are trying to enhance performance, enhance strength, whether it's sprinting or long distance or weight work. It's still high intensity training you towards something. And the original traditional thinking in terms of health benefits was really we need to be working at that moderate intensity level and a little bit of that high intensity. And really that aerobic max side of things and the high intensity interval training, that was really only for those athletes who were trying to improve their performance. But actually the newer thinking, and it's 10 years old now, so it's not that new, but that newer thinking is maybe working at these higher levels can give us some health benefits. And it can give us these health benefits much, much quicker. So this high intensity interval training, as it's called, so is HIIT a safe and time efficient alternative to moderate aerobic exercise? Can we start to get the same health benefits in less time per week? Because few people realistically achieve the recommended amount of 150 minutes per week plus those 2 additional strength training sessions. It's not realistic for the large majority of the population. So the HIIT protocol, really, this is just a crude protocol, okay, and it's just showing power on the left-hand side on the y-axis and then your time on the x-axis. And all it's showing is you do a bit of a warm-up, and then in this particular case, you do a minute at high intensity, so you're working at maximum rate or close to maximum. Have a couple of minutes rest at a lower rate, and you do it again and then again. So basically, high intensity interval training requires 3 to 9 minutes of intense exercise per week. And there have been lots of studies on this. Okay, so some studies are going for 2 weeks, some studies going for 4, some studies going for 6, some going for much longer. But the whole point about a lot of these things is that you can actually do this very same protocol, and you can do 2-minute warm-up and then 20 seconds. Another 2 minutes, 20 seconds, another 2 minutes, 20 seconds, and you're done. And you can do that 3 times a week. Or you can go for 40 seconds or 60 seconds. So the studies do vary. But the whole point is you just have to do it 3 times a week, and it can last from as little as 3 minutes per week of intense exercise with a bit of warm down and warm up. So the real question is, can this really not particularly time-consuming type of exercise, can it improve your glucose tolerance? In other words, how your insulin works, so your diabetes risk. Can it improve your blood pressure, your lipid profile, so that's your cholesterol, your bad cholesterol and your good cholesterol? Can it alter the plasma markers of other diseases or disease susceptibility? Do we get a change in our VO2 max through doing this HIIT, therefore improving your overall morbidity and mortality risk? But also, do our genes influence our responses to this? So does your genetics influence your response? So lots of studies have looked at this. So one of the earliest studies actually looked at the effects of high intensity interval training on aerobic capacity, on that VO2 max, on your ability to use oxygen efficiently. Remember what that's looking at? That's looking at how good your heart is, how good your lungs are, and really how good your blood vessels are, but also how good your skeletal muscle is. And if you just look at this little table, it's just showing it improves aerobic capacity, but it seems to return towards baseline when you stop that HIIT. So in other words, if you're looking at this graph, your VO2 max in the pre-HIIT people, so before they did 6 weeks, this is only 6 weeks of high intensity interval training. This particular study was only doing 3 minutes per session. So it was 9 minutes of intense work per week for 6 weeks. And you can see that the average VO2 max of the people in there went from about 48 mils per minute per kilogram up to just shy of 55 after 6 weeks. And then a 6 weeks detraining program, you saw it coming down again. And so this is quite good, and there have been lots and lots of other studies to show this. But other things that this and other studies have shown is that you're seeing similar average improvements in glucose tolerance, so the ability of you to use insulin. So in other words, your diabetes risk. Still all changes in blood pressure, reductions, your lipid profile improving, so more good cholesterol and less bad cholesterol, as well as lots of other type 2 diabetes risk factors. So it does seem that this really low time consumption, if you like, can still give those same health benefits. And they're giving those health benefits in some studies gone down to 2 weeks and seen health benefits. This one was 6 weeks that I'm showing you now. Whereas your moderate aerobic exercise over 150 minutes per week, that takes, around about the 4 to 6 month period to start to see those health benefits. So the health benefits seem to be kicking in a lot sooner in this system as well. So what it seems and there's a lot of research to show this, okay, so I just gave you a little bit there. So there's a lot of research to show that HIIT actually seems to have removed the time barrier for removing health risk factors, for giving you potential health benefits. And that amount of exercise that you can do, depending on the study and depending on what you want to do, it can be between 1 and 3 minutes per day, 3 times a week of intense sprint cycling. That's where they've done it mainly, is in sprint cycling. And that decreases your type 2 diabetes risk and potentially provides cardiovascular health benefits. Of course, it doesn't have to be cycling. You could do sprinting on the spot. You could be doing burpees. There are all kinds of things you could potentially be doing if you wanted to monitor this or change this. And so, of course, if you're changing the exercise type, but it's still high intensity interval training, it can be done at home. It can be done in your office, or it can be done at university. It can be done anywhere. Studies that have looked at it, they see the enjoyment has increased and compliance has increased because they're not having to go out for vast amounts of time to get health benefits. It can be done very quickly, and it can be done with other people. And is it safe? Well, it's been done with diabetics, it's been done with cardiovascular disease patients, all under screened and supervised programs. But the whole point is it's been done and it's been shown to be as safe as realistically possible. So what I just talked about really was just showing that high intensity interval training and moderate exercise, they have very different time consumption or time usages. So high intensity interval training, you can get it done much, much faster in a week, and the health benefits seem to kick in a lot quicker as well. But also what's really important, and this is very new stuff that's starting to come out in the last few years, is we really need to think about the relationships between non-responders, positive responders, and adverse responders to exercise. So, and the whole point about all the studies that have been done to date, they've all been based on averages. So when people have done exercise, they've gone, the average person gets an improvement in blood pressure. The average person gets an improvement in VO2 max. But what about those people who don't get an improvement? What about those people who potentially have an adverse response? And it's been ignored for many, many years. And so all I'm going to show you now is just data from the first paper to really talk about this. And so it was only 5 years ago the first paper talked about it. And what it brought a whole load of studies together, and it really showed that 50% of people following, this is moderate aerobic exercise, but the same kind of responses are seen with HIIT. 50% of people show an improvement in their systolic blood pressure following aerobic exercise, moderate aerobic exercise. That's great. So 50% of you listening to this will get an improvement in your systolic blood pressure. It will get lower. But if you're looking at the other end of the scale, 12% of you will have a systolic blood pressure that goes up. It gets worse following exercise. Okay? It does mean, of course, there are 38% of the people who have no significant change. They're called non-responders. So you've got the positive responders who get an improvement, the non-responders who get no significant change, and then you have the adverse responders who have an adverse response, whose blood pressure, in this case, blood pressure gets worse. And there have been lots of studies on this, okay? It isn't just these guys, but it's been shown in healthy sedentary Caucasians, American blacks, mixed race, obese, type 2 diabetes subjects. So there are positive responders, there are adverse responders, and then there are non-responders in all of these studies. And with blood pressure, it's particularly important if you think about it. What if you've got high blood pressure? What if you've got hypertension? And your GP says, right, go and do some exercise. That reduces the blood pressure in 50% of people, and you should be one of those. Or hopefully you'll be one of those. But what if you're an adverse responder? What if you've got a high blood pressure and your blood pressure gets worse, goes up even higher, and you have a stroke because you've been recommended to do some exercise to reduce your blood pressure, but you're an adverse responder. So that's not a good thing. And then if we just look at a couple of other variables, okay, just to make a point about it. So most people show an improvement in their insulin action. So 65% of people, they're the positive responders. But again, we get adverse responders, about 8% in this case. So their insulin action gets worse. So if you're a type 2 diabetic and you've been told to go and do some exercise to improve your insulin sensitivity and you're an adverse responder, your type 2 diabetes gets worse. Again, that's not a good thing. And likewise, if we look at the last one in this particular side of things, most people, about 70%, have an improvement in their HDL, high density lipoprotein. That's your good cholesterol. Okay, and that's the one that mops away the bad cholesterol. But there are about 13% of us are adverse responders. Our HDL gets worse. And if our HDL gets worse, it means we're more likely to get atherosclerosis. So in other words, we're more likely to get cardiovascular disease. What if we already have cardiovascular disease? We're told to do some exercise and our HDL gets worse. That's not a good thing. So the real question is, how many adverse responders are there? And actually, more importantly, to you listening to it, are you one of those adverse responders? Do you have, even if you're thinking, oh, I'm really fit and healthy, I'm doing lots of exercise, but you don't know whether your health risks are changing because of your exercise. You might be getting faster, you might be getting stronger, but are you actually getting healthier? That's something that you probably don't know. So I'm just taking an example that came out of this paper that I just showed you. So they looked at 4 different variables. They looked at insulin, so diabetes susceptibility. They looked at HDL, so your good cholesterol, and triglycerides related to your lipid profile as well. And then they looked at resting systolic blood pressure. And they had a look at how many people out of the vast population that they had been studying were adverse responders. And what they found out of those 4 variables, they found 31% had one adverse response. So it might have been in insulin, it might have been in HDL, it might have been in triglycerides, or it might have been in systolic blood pressure. They found 6% had 2 bad responses. They found just under 1% pretty much had all bad responses. So either 3 or 4 of their variables were adverse responses. So in other words, their fasting insulin got worse, their HDL got worse, their triglycerides got worse, their resting systolic blood pressure got worse. Or 3 out of those 4. And now that's, you might think, 0.8%, that's not very many at all. But actually, 0.8% out of the population is a vast number of people. It's a vast population. What about the 0 adverse responders? Well, clearly that's the rest. That's 62 and a bit percent. So thinking about you and your class, say there are 100 of you in your class, it means 62%, 62 out of the 100 of you will not have any adverse response. But 31% of you will have one, and there'll be one of you in there, one poor individual who will be classified as a global or a universal adverse responder. There are relatively few of them. Most people get some positive benefits from exercise, but you may also get an adverse response, but a very small number of people will get 2, 3, or 4 or more, because remember, you have far more risk factors than just those 4 showing there. Okay, so you may be a universal adverse responder where exercise does you more harm health-wise than good. So the question really is, are you a non-responder or are you an adverse responder to exercise? Do we know? Can we look at you to find out? And actually, the problem is we can't look at you to find out whether you're an adverse responder or a non-responder or a positive responder. It's not based on height or age or weight or your mean arterial blood pressure or your heart rate. None of these things help us determine whether you're a responder or a non-responder to exercise. So how can we? Can we actually spot the responder types? So something I just want you to think about, there's a lot of genetics involved in exercise. There's a lot of genetics involved in everything, obviously. So can genomics be used to spot an adverse responder or a non-responder to exercise? So just to put it into context, your aerobic capacity, that's your VO2 max, that's about 60% genetic. Okay, your insulin sensitivity is about 40% genetic. Your change in strength is about 50% genetic. So there's big genetic influence on aerobic capacity, on insulin sensitivity, on strength. It's not all about training. It's also about your genetics. And these are ballpark figures, okay? And it's very likely that a single gene change only explains a very small difference between individuals. So really you need to find a lot of genes. There are vast numbers of genes. And there are potentially millions of genes that influence your exercise responses. So how on earth can we just look at you or even take your genetics and work out whether you are a responder? So can we predict who will respond to exercise? Well, believe it or not, yes, we can. So there are studies out there, they're very recent studies, only in the last 5 or 6 years, where we can actually predict whether you will respond to aerobic capacity. It's the only one that we can currently predict. And what they did in this, they did genomics. And don't worry too much about what genomics is, but all they did is they looked at your genetic profile and the various proteins that you were making, and they looked at the levels of those, and they could predict by those levels, and they're non-exercise responsive levels, they could predict by looking at those levels whether you would be a responder or a non-responder to VO2 max. So in other words, the studies they did, they took your genetic profile, they predicted whether you would get better at your VO2 max with HIIT training in this particular case. You did the HIIT, and then they predicted it, and they got it right. So they could predict whether you respond to exercise or not for VO2 max, for your aerobic capacity. It's not possible with those other variables at this stage. So the whole point about this is, yeah, we can predict these things, but we can't do it very well at the moment. But in the future, it's possible. So every exercise training study has got these adverse responders to exercise. You may well be one of them. I may well be one of them. So do we need to individually adapt exercise recommendations? Well, yes, of course we do, because we all respond differently to exercise, just like we all respond differently to drugs. Can we change a non-responder or an adverse responder into a responder? Well, not at the moment, but is there the possibility that we can? Can people do high-intensity interval training? And if they're a non-responder there, if we give them moderate exercise, do they become a responder? Can we use supplements? Can we give creatine as a supplement, amino acids or bicarbonate? These are commonly used things in people who exercise. As well as enhancing performance, can they potentially help someone turn from a non-responder, an adverse responder, into a positive responder? No one knows at this stage. So therefore, the real question is, can we prescribe exercise for disease treatment? Of course, at the moment, people say, yes, we can. But is this realistically true? Because these adverse responses make this very difficult. For example, it's not good for someone with hypertension to have an increased blood pressure following exercise. It's not good for someone with type 2 diabetes to have increased insulin resistance following exercise. So like I said, it's well known that individuals respond differently to drugs. You have an adverse response, little effect, or a positive effect. Exercise responses seem to follow the same pattern, and we really shouldn't be surprised about that. They both seem to have a genetic influence on them. So if we're thinking about the future, where are you and what can you do? So of course, a lifestyle program will on average reduce the risk of you developing type 2 diabetes and reduce progression if you're already diabetic. It'll also reduce on average other disease risks. It's not known whether exercise alone will reduce these risks, okay, because they haven't done exercise alone studies in high enough detail. So they often do them with dietary changes, for example. And these are very long-term studies when you're looking at cardiovascular disease. These take 30 years to progress through. And if you have an ill health risk factor, you may not benefit from exercise. So on average, no effect is about 20%, and an adverse response is 12% for any one risk factor. And remember, if you're one of these universal adverse responders, basically exercise is making your risk factors worse in a lot of different cases. So the moral of the story, of course, it's genetics, or a lot of it's genetics. Make sure you choose your parents wisely. Thank you guys, and we are finished.